Hello, everyone. My name is Giovanni Nogales. I'm a paralegal here at Liles Parker. Thank you for joining us for this new webinar series with the Home Care Association of Louisiana. Today's webinar is entitled Practical Advice for Strengthening Your In-House Home Health and Hospice Compliance Program. How will the DOJ assess your compliance program? Our presenters for today are Robert Liles and Paul Wakefield. This is just a quick reminder. If you have any questions throughout the presentation, please feel free to type them in the chat box and we'll address as many as possible at the end of the presentation. So without further ado, I present your speakers, Robert Liles and Paul Wakefield.
Thank you very much, Giovanni. This is Robert Liles, and I'm here with my friend Paul Weidenfeld.
Hello, Robert. How are you?
Hello, Paul. Now, a little bit of background. I'm the managing partner here at Liles Parker. For many years, I was an assistant U.S. attorney in the Southern District of Texas, and then came to Washington as National Healthcare Fraud Coordinator. My friend Paul, however, his background is especially pertinent today because he was actually a federal prosecutor in New Orleans.
I was.
And he has actually prosecuted civilly and criminally home health and hospice cases. So today, Paul, what we're going to be talking about, and Paul, by the way, is one of the owners and founders of exclusionscreening.com. So everyone on this phone call ought to be making sure that you are screening your employees, agents, and contractors, because if you fail to do so, it can cost a lot of money and it can result in you being kicked out of Medicare. So that is the most important, least understood risk area for home health and hospices around the country.
Absolutely it is. And so just so you know, you really do need to screen. You can call our company, Exclusion Screening. You can check with others as well. We're not the only service. They're not the only provider of this service, but please be sure to do so because frankly, home health and hospice, exclusions keep people are intended to keep people away from
bad actors.
And they're always the target on the back are people who are in the trenches dealing with patients and dealing with people. And home health and hospice is often targeted for exclusion violations. Other than that, let's go on, Robert. Let's talk about compliance.
All right. So we're talking about an area that has been around forever now. It feels like, although you and I were actually involved when Christ was a PFC, as they used to say. But when they first issued the guidance, when OIG first issued the guidance on compliance for home health agencies, hospice agencies, physician practices, nursing homes, labs, the whole 9 yards.
Feels like it's been forever, Robert, because we've been around forever.
Well, that's true. That's true. And you have to give OIG credit, because this is something that, this whole idea of a compliance plan, it's something that everybody talks about today. But the fact is, it wasn't really there then. As you know, Paul, I've worked in healthcare for a long time. Since 1984, I've worked in hospitals, and then I went to law school after that.
Right.
In those days, we didn't have a compliance officer. We had a risk management officer, and the sole job of that person was handling medical malcases. That's it.
That's right.
So, when OIG came out with this whole idea of compliance plans, it really was quite innovative.
It was the idea was to move, it was pay and chase in the beginning, and you've heard that, and there was the overpayments have been an issue almost from day one, certainly for many, many years. And so the idea was to have a self-compliant kind of self-policing medical system. And the way they would police yourselves is by having a compliance plan. That is, the providers would create the rules of the road or their agencies or their type, and then they'd follow them. And so the way that, and so they were trying to figure out, well, how do we move into the self-policing movement, so to speak? And they said compliance plans, but not all are the same. And so, Robert, they kind of went to work in 1998 and created a bunch of them. Huh?
They did. And home health, of course, they were one of the very first ones that were targeted because, frankly, they thought that home health agencies at that point had some of the they had a lot of problems.
I prosecuted criminally home health agencies back in that day, a long time ago, and they were different. They were all And so they were high at the hospitals will serve. Home health was really the first smaller provider that got its own compliance plan.
And it wasn't long after that hospices, they issued guidance for hospices. And we're talking, of course, about the suggested compliance guidance. At this point, it was still considered to be voluntary. Now, there's still, even today, there's quite a lot of debate of whether or not these things are voluntary or not. Were they mandated by the Affordable Care Act? It doesn't really much matter because frankly, under most of the Medicare Advantage, Medicaid managed care plans, now by contract, you have to have a compliance plan in place.
And Medicaid, it requires them pretty much universally.
Medicaid traditional does, that's right. And so in many states like Texas and I believe Louisiana as well, they've actually codified it as part of the rules. Mm-hmm. So, it's no longer voluntary. You have to have a good plan. Next slide. And these are just a couple of quotes that I pulled out from the 1998 and 1999 guidance. But the bottom line here was, under both of these sets of guidance, is the government really wants providers on their own to stay within the four corners of the law. That was it. Next slide.
The importance of these is not to have. The reason they had so many different plans, but there's 12 listed on the first slide, and is to make them unique to your agency. Not all home health agencies are going to have exactly the same risk areas, although theirs will be very similar, but their risk areas are going to be a lot different from hospitals and a lot different from other providers.
That's right. That's right. So that's why there are significant differences between home health and labs. Right. But really the differences are not in terms of the elements, the core elements of a compliance program. It's really the differences, as you say, between the risk areas that they run across.
And the last line on this slide, there is no one size fits all, really focuses on the obligation of the provider to think about and respond to the risks that they have to deal with. And that's what we're going to be talking about, the risks to hospice and the risks to home health agencies.
That's right. Okay, next slide. All right, so what are the benefits? I mean, this is old news for most of the people on this phone call, but let's just go over a few of them. Some of the benefits of a compliance program, they think it's evidence of good faith. If you have a real bona fide living and breathing compliance program, it's if you have to go into the closet and you're still storing it with the old yellow pages, that's not a real compliance program.
Right. No, you've got to have your own. And there's two ways to looking at them. One is, so as you can see, like you get the benefit from sentencing, and you shows good faith if you come up and you have proper billing. But so those are the risks. Those are the benefits when you're being looked at by a government agency in terms of an investigation or an audit or what have you. But the other side is it really creates within the agency, a framework, the proper framework within which you're going to do business. Here's how we're going to do billing. Here's how we're going to interact with our patients. Here's our culture. And so it's defining who you are and how you provide your services as well. So that's an important benefit. It's important not to lose sight of the benefits to the agency and its the way it operates. Would you say, Robert?
Yes. Next slide.
Thank you.
All right. So what should you not do?
Well, don't cut and paste. Don't go to the internet and type in, I need a compliance plan for my home health agency. And when the first ones pop up, you can see, oh, that's a PDF. Pull that down, and there it is. That's not going to do it.
And it's really kind of misleading because there are a number of very large home health and hospice companies around the country, and some of these have their compliance plan online. And when you look at it, you're like, oh, there's nothing to that. It's 4 pages long, or it's 8 pages long at the most. But understand, just because they have something that outlines the 7 elements of compliance, okay, that is not the totality of their plan or their program. The fact is that's just an outline of the general principles that they're having to meet. But when it comes down to figuring out what your risk areas are, I mean, that could be pages and pages and pages of guidance and policies that you have to figure out.
So what you start with is you're doing what we call a gap analysis, and it's not generally accounting principles analysis. That's the gap between what you should be doing and what you are doing, because frankly, you may not be doing everything right.
And you have to figure out what that is.
Right, you got to figure out what's right, and then you got to figure out where you are, and then how do you bridge that gap? And that's really what it's about, isn't it, Robert?
It is. It is. And that's kind of scary, because especially for agencies that this is the first time they've ever really done a real life assessment of their activities, it can be kind of scary because they realize for the first time, oh my gosh, we've been doing this wrong. Right. And, does this represent an overpayment? Does it not represent an overpayment? Is it, because understand, just because that you didn't do everything perfectly does not necessarily mean that those services don't qualify for coverage and payment.
Right.
Okay, it just means remedial action's probably needed.
So you don't start from, you start actually from looking within. You look at what you do, and then you see how that measures out what you should do. If you start from the top and say, oh, these are all the things I'm supposed to do, I don't think that's the way to do it. I think you got to look at what you are doing.
You got to do both, really.
And measuring yourself up.
Yes.
But it really is about looking at yourself and having a true internal evaluation of what you are as compared to these seven elements.
These are the basic 7 elements, aren't they? These are the basic 7 that OIG came out with when they first issued the suggested guidance for home health and hospice. These are the basic 7 elements. Okay.
Now, those elements, they are, as we'll see, look at the next slide.
Well, before we do that, I will say that, in my opinion, one that because we're going to talk about today how these 7 elements changed, how at some point DOJ actually weighed in for the first time on compliance programs and said, well, if you want us to consider this to be something that is going to impact our investigation, you better have certain things in place. But the one element I think that really is the most important, and they're all important, but the most important is internal monitoring and auditing. Okay, that I believe is the key to compliance.
And it's interesting because if you Google the 7 elements, okay, you'll get about 7 different versions of the 7 elements, and these are not the way they currently have them listed.
That's true.
That said,
these are the originals.
These are the originals.
OG. Original gangster compliance.
Right. Anyway, and what you see here is, as Robert says, monitoring and auditing is at his top of the list, and that kind of gets shoved down in the subsequent list.
It does. It does.
But I'm in full agreement with him on this point. Not always, but on this point, because I think most everything falls into that. Because when you're monitoring and you're auditing, you're looking at yourself and you're doing that analysis.
Yeah. So it presupposes that you've done that initial gap analysis to begin with. That first day, it's like the first day of school. What have we been doing? What are we supposed to be doing? Figure out what that gap is, fix the gap. Now, going forward, we need to be periodically checking to make sure that we're staying on course.
And one of the changes, this was not an official OIG compliance guidance. This was done with their assistance with HCLA. They worked on it together. It's 60 some odd pages and it's very dense, and it's worth looking at for all of the things that might be helpful. But one of the interesting things about this one is number 3, where they're talking about screening and evaluation of employees, the physicians, and vendors. And this goes well beyond exclusions, which of course would fall into that.
Right.
But this really talks about, the first thing is auditing and monitoring, and that's number 1. But I think 1A is looking at who you are employing and who you're doing business with and who's providing your services. Because if you think about it, particularly in home health and hospice, where do your true risks lay?
It's with your people.
With your people, right, Robert?
Yep.
It's going to be with the aides, or whoever's providing the service, whoever's going into the homes in home health, whoever's with the patients in hospice. They are the ones that provide the risk for the billing, because they do it, but they provide the risk relating to the medical record. They provide the risks related to just, to the patient.
Yep.
It's all about who you are, who's running your business, who's involved, your people. They are all, we could do a risk analysis. And so it really is critical, those two elements, looking at who you're doing business with.
It goes a long way towards compliance.
And if you do that and you audit and monitor, I think you're most of the way home. But
I think so. But I would like to point out, this is why I tell people Mama was the first compliance officer, right?
I love that line.
It's the truth, though, because Mom always said, if it's not yours, give it back. And she also said, you're judged by the company you keep. Okay? So if it's not yours, give it back. That's auditing and monitoring. Okay? And judged by the company you keep. If you're screening your employees, your agents, and your contractors every 30 days like you're supposed to under Louisiana law and under OIG's guidance, then you're keeping bad folks away from your patients, and you're reducing the likelihood that they're going to rip off the federal fisc.
And there's one other thing your mama used to say, I'm sure. She said, just because Jimmy did it doesn't mean you can.
That's right.
That's right.
That's right.
And that's important too, because just because some other agency
is paying marketing people,
right, or they're doing something like that, doesn't mean that you can do it as well. That does not. It's not the standard.
No, it's just because they're breaking the law doesn't mean you can. Thank you, Mama. That's exactly. But these are basic life truths.
They are.
That have been with us since we were small children, and they're still true today.
And so carry them into your agencies, carry them into your work is kind of the message that we're giving.
Yes. Next slide. So let's talk about some of these risk areas. And this is something else that I think is just fascinating, is when I put these risk areas together, I primarily use the risk areas that they identified for home health in 1998. Look how many of these are still current today. It's unbelievable.
Absolutely.
Okay,
right.
Homebound status, face-to-face documentation failures, improper employment of excluded individuals. Just all kinds of non-qualifying plans of care. Improper marketing. Oh my gosh. Guys, marketing in and of itself is not illegal. But remember, under the anti-kickback statute, conduct that is perfectly legal in every other industry is likely illegal in healthcare. Okay? So if you're currently employing marketing people for your home health or hospice, you better make sure that you talk to your healthcare attorneys to make sure that whatever they're doing falls within one of the appropriate safe harbors.
Failing to meet, and that's absolutely true. And if you look further down, it's talking about the improper inducements, which is sort of the stepchild or the of what you're talking about.
And for home health especially, let's just use Texas as an example. Louisiana, it's kind of been quiet the last few years, knock on wood. But in Texas, it hasn't. And in Texas, almost all the home health cases they've brought have been based on kickback-related allegations, either kickbacks to patients, kickbacks to doctors who are the referral sources, or kickbacks to marketing people who were being used as independent contractors, and their relationship did not meet the safe harbor. When it comes to home health and hospice investigations, the government, the first thing they're going to do is they're going to see, where do you get your business from? Where do you send your business to?
And the next thing they look at is medical directorships.
Oh my gosh, yes.
Because that is money being paid properly. And, both of us have been in this business for a pretty long time. And I don't know how many times I've seen good documentation by the medical director.
I can tell you how many. Zero.
And so this is it's so crazy, and it's been going on for so long. You have to have your medical director. It is an important function. The medical directors are providing important services, but they also have patients there. And so now and they're
sending you referrals.
And they're sending you referrals.
Which is not illegal.
Right. So,
Yeah, because Paul, when the government comes in, to your point about documentation, they're going to say, oh, I see that Dr. Jones made 3 referrals to you on the average per month for the last year.
Right.
And you're paying Dr. Jones $2,000 a month. We want to see his records showing what he did on a fair market value basis for $2,000 a month. Chances are he has no documentation, or if he does, it's very thin, very skinny.
he always, the typical answer is, well, I look at my calendar. Oh, yeah. And so I went to this meeting here and I did this here. But he really doesn't distinguish between what he's doing for his patients and what he's doing for the agency as the medical director. And he absolutely has to. And when I went into Department of Justice, I had criminal and civil experience, but the criminal prosecutors had one mantra, which is follow the money. Okay, that's where they go. The first thing they're going to look at is where do the dollars flow out, not in, because they know where they're coming in because they're the payer. Where's the money going out? And the money's going out to the medical director, and the medical director they just don't keep good records. They're in almost all circumstances, they were absolutely providing the services that were certainly worth $2,000 a month or whatever they got, and well more than that.
But the problem, though, is prosecutors say, show me what you were doing.
Right.
And there's no records. The prosecutor then jumps to the conclusion, not completely off base here, that, well, if there's no proof that he was really doing anything of value, then I must conclude that the only thing that they were doing for the $2,000 a month is they were getting kickbacks.
The follow the money is,
for the referrals that they were making.
Proper inducements, kickbacks, medical directors, that's, the money that's going out. Obviously, all of the other things, taking care of your patients is your primary focus. I understand. But the government, that's not, when criminals coming in there, that's not what they're looking at. They don't, I won't say they won't care about that, but that's not, they're figuring it's something else.
Next slide. All right, now we'll very quickly look at the hospice risk issues. Now, it's interesting to me, even though this goes back to 1999, uninformed consent, okay, that's been something that they identified almost 26 years ago as a possible risk, but it's only been a handful of years, fairly recently, last 5 or 6 years, that now that is at the top of the audit list when they're looking at hospice claims, because they want to make sure that these patients were properly notified what they were giving up when they chose hospice. They've given up curative care, and was an informed consent that they have in the file. So maybe 10 years ago, you could lose that piece of paper and not have to worry too much about it. That's not the case any longer.
Should be in the front of the file.
Yeah.
Absolutely. Along with all the other intake information. Another thing is, then probably the biggest, and this is going to come as a shock to nobody, but is length of stay.
Length of stay is always huge.
It's always
it's almost as important on the home health side, but it's especially pertinent and important on hospice.
And the thing is, you can't, I've always taken the position that if I have an order from a physician, that should be enough, right? Because why can't I rely on the doctor's order that this patient continues to qualify for?
They have a terminal illness and
they qualify for hospice. And who knows how things work in this world? God, whatever's going on, are they allowing someone to live longer than their whatever? But I have an order, and it should be okay. But the government just doesn't buy that. And that's really, a universal, I think, unfairness and an issue with it. You can't, and you have to kind of go behind and make sure.
Mm-hmm. Because now you're having to justify why they're still alive after 6 months. They don't really typically go after somebody just after 6 months. No. They wait till they've been there on service for a year or longer.
Right.
And then, that's when they start asking questions.
And the thing is, they should be, in my opinion, they should be asking the doctor who wrote the order, but they're asking you. And so you really have to have some kind of mechanism to respond to that.
All right. Hospice incentives to referral sources, same problem as we see with home health. You've got your marketing problem. You've got your medical director issues. It's really the same issues that are out there. most hospice cases, I mean, although the government's getting a lot more sophisticated, okay, and they're actually looking at, was the patient really terminal? Early hospice cases, though, just like their home health brothers, were almost always kickback related.
That's true.
But that's not the case now necessarily with hospice. The government's gotten a lot more sophisticated as to how they're analyzing these things and holding providers' feet to their fire when it comes to the qualifications under LCDs. Now, you know, Paul and I could do, we could do 3 hours just on, are the LCDs binding or not? Okay, but we're not going to do that today.
No.
But that's something that you have to worry about, because that's what the government is using as a measuring stick.
Another big issue that I would call attention to, and that goes back forever, is amendments to medical records, making amendments to them. A lot of times, medical records are not complete. You have labs hold open. And so, oh, well, I'll leave this. You know, it used to be with written stuff, you could easily go back. But
Right.
now, you're supposed to close it out. And now people the record isn't closed out because they want to add the labs, which they know are coming, but then they don't, and then they add,
Next slide.
they find it 4 days later.
Oh,
And
okay.
so, in other words, as we always say, Robert, it's always okay to amend the medical record
Or to supplement it,
or supplement and add information,
right?
but
Always date it today. Date it the day that you made the change, okay?
and if you
Don't
think
ever backdate anything.
and if you think it looks funny because it's actually a week later,
Or a year later even.
which is, so you found the labs, oh my God, it's not in the record.
What
know?
are we doing? Yeah. we need to
But-
have it.
You make an explanation as to why. There is nothing wrong with saying this is being added 6 months later because the lab, we thought it was in there, but now we found in the results and we see it wasn't in there. So
Or we've seen situations where the labs were in there, they made a care decision based on the labs.
Right.
But the narrative didn't match up what they did, so they realized I misspoke. Or when I typed it out or when I dictated it, so I got to make that correction. I need to make it now.
there's any number of reasons why records have to be updated, why they have to be amended. It's always okay to do it. It's never okay to do it in a way that makes it look like the change, like it was part of the original record.
Yes, exactly. All right.
So, where are we, Robert?
Okay. This is fairly recent. In the last couple of years, OIG came out, and earlier
Oh, yeah.
we had the whole list of all the compliance guidance that they had issued. And the compliance guidance covering everything from home health to hospice to labs to managed care, everything. In 2023, OIG said, we're not going to be doing it that way anymore. We're no longer going to be issuing updated suggested compliance guidance in the Federal Register. Instead, from now on, we're going to put it on our website. And we're going to have a general set of compliance guidance, which they've already issued, and it's on the website. And then, as needed, they're going to issue industry-specific updates and put those on the website as well.
And I think this is familiar to the trend which I hate, by the way, the trend of manuals. When you want to go to a provider manual, and you want to see everything at once, and then they'll have one general set of rules and regs, and then they'll have, if it's outpatient, go to this one, if it's this, go to that one, and so it's of that same thing, which I think is really hard to figure, but that's the way they do it. And so,
and what bothers me, of course, is it's a little bit like CMS, how they'll say that this is what we recommend today. And if it's in the Federal Register, then you've got an actual record of it. Versus if it's on the website, they could change the website, they could change the guidance, and maybe you can find it on the Wayback Machine, but chances are,
right.
No,
right. It's true. When they make changes, the changes aren't clear.
It's hard to figure out.
Oh.
Well, we were doing it that way because what you told us earlier. Oh, really? I don't think so.
Yeah, that is problematic.
Next slide. All right. So far they have issued the general guidance that's out there. They're going to be issuing additional guidance on labs and hospice coming up, but it hadn't happened yet. Okay, so they're working on something with hospice, but it's in the pipeline, but there is no date on when that's going to be released. Now, in the backdrop of all of this, remember we've talked exclusively so far about OIG and the things that they've been doing. Okay, next slide. Well, it turns out that DOJ, I mean, while they were 18 years late, but they did enter the picture or so in 2017, and they said, okay, well, everybody, we have all these civil and criminal cases, and these providers are coming to us saying, look, we weren't perfect, but we were trying to do the right thing for the right reasons, and here is the guidance that we put in place internally to try to do that.
I find it fascinating that, interesting. I don't know about fascinating, but I find it interesting that they start, these are how they're going to treat folk, how they're going to evaluate in a criminal context.
Somebody's compliance program.
Right. In order to, for
sentencing, for figuring out whether or not intent was there, but possibly even, determining liability.
But the original 7 elements came from, as you know,
the sentencing guidelines.
The sentencing guidelines, which were that predates all of it, but 80s.
By 30 years.
I think it was 1984, I believe, was when those sentencing guidelines came out. And so those were the original 7 elements, which the OIG adopted in their compliance guidances in the 90s. And so now they're coming out like they haven't been around. It's kind of
it is kind of weird.
I
mean, but especially. I mean, maybe it's just me, but it seems to me like they've kind of made things a lot more complicated.
Yeah, and I don't really know. I look at these things, and I think they're important, and we're going to go through them. And instead of the 7 elements, they ramp it up to 11.
They have like 11 things they want to look at. Yeah.
And they do. And as we're going to see, we're going to roll through this. There have been 4 updates to this thing.
There was the initial issuance of this in 2017. So let's go to the next slide. Okay. And this kind of lists those 11 things that they want to look at. And these are the same 11 things that still exist today. But they have still made changes to what they call the ECCP. And the ECCP is the
evaluate. Who knows what those things stand for? Evaluation of the Corporate Compliance Program.
That's exactly, that's what it is. All right, so go to the next slide. All right, so they had those first 11 when they came out with the first 11 factors or components, questions, whatever it is. Then in 2019, 2 years later,
the first one was on risk-based, and the second one, try the next slide, Gio.
Yep.
And this one was more, we want you to have some focus on data analysis.
Yep. And M&A due diligence,
That's a weird one to me.
It is, except it's weird and it's kind of scary, because what they were saying there was, if you buy a company, okay, and once you buy the company, even though you've done proper due diligence on the front end, let's say you buy a company and you go through and then you find all kinds of problems. If you bring those problems to us immediately, and I think that there's actually guidance as to how long you have to bring it to them, okay, then essentially we'll give you a pass and we'll go after the old owners.
Right, because as we know, the number passes. You can't just buy it and then and then move on and leave the liability behind you. It doesn't work that way.
But this is bad in the sense that it incentivizes the new buyers to screw the old buyers or the old sellers.
There is quite a bit. This has led to quite an intense sort of. It has though. There is some benefit to it in the sense that when you want to get, a lot of people want to sell their business because they know about issues and they just kind of.
Maybe it's a good time for us to get out.
Yeah, kind of like, right?
Yeah.
And so it really has ramped up what the when they're doing when they're looking at the risks, when they're in.
But keep that in mind, because everybody on this phone call right now either owns a home health or hospice or works at one.
And if they have been bought or sold.
Yeah, if it ends up being sold again, just make sure that you are completely transparent with everything, because whoever buys it, essentially there is a push, an incentive for them to dime you out the first chance they get.
So they also start talking about third-party management, which is interesting in that they're finally starting to look at, that sort of thing. And then this is a third up, but all of this is just sort of, well, these are things to more focus on.
Yeah. So the third version, then they said, and plus we're concerned about the way you're paying your managers and officers and owners and the rest of it.
But they've always been worried about that.
Yeah.
Anyway.
So, what are you giving their bonuses based on? Does it lead to bad conduct? Or are you incentivizing the wrong things? That kind of thing.
But here's the one I have a real question on, and I don't mean to be snarky on this, but how do you start measuring a culture of compliance? How do you measure that?
Maybe the number of hotline complaints that you get.
I don't know.
I don't know. The number of paybacks that you make.
I mean, the culture of compliance is critical, and that is kind of the basis of the whole point, or not the whole point, but a huge point of compliance plans and self-governance and self-policing is having a culture of compliance.
But have they taken self-policing too far to where it's almost like an East Germany culture of everybody watching everybody?
That may be, but I don't know how you could possibly measure that culture.
I don't either.
There isn't. But anyway.
All right, next slide.
They're going to measure it.
Yeah. Another update. Okay. There we go. Use of data and technology, especially AI. This is really an interesting one to me because it was, I guess it was February of 24 when DOJ came out and said, if you commit fraud and we find that you used AI to commit fraud, we're going to go after you with the most penalties and sanctions and the rest of it.
I truly don't understand that because AI, I mean, when you have a drop-down menu, that's AI, right? They're making suggestions on which code to use. They're making suggestions on what, I mean, that's AI, and that's been since the first electronic health record. So I don't really know what they're talking about. All I know about AI is I tried to get a medical record because I needed it, and all I could get were answer phones, right? And that's AI, right?
Yeah.
That's and all they could do is tell me we can't help you. Here's a number to call, which would tell me they can't help you. So I don't know how effective AI is.
I don't know either, and I also don't know because there's a whole new series of Wiser audits that CMS has now initiated using its contractors that uses AI to conduct these audits and identify targets. So,
which is the same thing as data mining, isn't it? Really? Essentially,
I think it is. Yes.
I mean, it's like looking at numbers to find targets because anyway. So
all right, next slide. So this is just a summary. We're not going to spend any time on that because we kind of talked about that. But
let's go to the 11 elements.
Yeah, let's go to the 11 elements.
Oh, there we go. All right.
Yeah. Okay. So the first one. These are now just to remind you what we're talking about here. These are the 11 elements or components that DOJ first identified in 2017 when they said okay, yeah, we think that compliance plans are important, but if you're going to want us to give you credit or to take those into account when it comes to our civil and criminal cases, these are some of the factors we're going to be looking at. Okay.
Yeah.
And the first one, analysis and remediation of underlying misconduct.
I think what could be defined as what happened.
What happened and what did you do?
Yeah. What happened and how did you respond to it?
Yeah, that's pretty much it.
Yeah, and there's a lot of bullet points saying.
Yeah, and did you take disciplinary action against the bad people that did the bad things? And if not, why not?
Which makes complete sense.
Yeah.
And I mean that is really, if you look at the 7 elements, that fits right in there as well.
It does.
So you got to figure out what happened.
All of these things, frankly, in my opinion, fit within the 7 elements. Every bit one of them.
I think they may all fit within either the first one of auditing and monitoring or the third one, which is looking at your people.
Yeah.
But let's go through them.
All right. Senior and middle management. Here, what is the tone at the top? You know, what exactly is management telling their people that they have to do or should do? And that kind of goes, I think, to the culture of compliance.
Yeah, and they're presupposing, that really presupposes a much larger organization than you know, they're looking at, you know, these large companies with middle management. I mean, how many providers can afford really to have many middle managers?
No, they're wearing every hat.
Exactly.
Okay. All right.
The next one is, so the first element in most of, and I think the regular compliance plan is, you know, you have to have a compliance officer who is not responsible just to the money side of it.
Yes.
Okay. And I think that's what they're saying here. Is compliance, you know, the problem is not a lot of agencies, a lot of home health agencies in particular, smaller agencies, can't afford to have a separate compliance officer that just does compliance. And so you've got to be careful. They'll mix the compliance officer with being an attorney. That's a very difficult role, which I would recommend against. If you're going to do it, you really need some guidance from a lawyer how to keep those roles separate. But most people will be, in many companies, Robert, it's like in the HR assumes that role, or somebody, or maybe someone who's directing. I don't know. But it's tough. But you have to have someone that is responsible specifically for compliance, for updating that compliance plan,
Yep.
making sure that it's up to date, making sure that you're making additions and subtractions and so forth.
And they need to be independent. And, you know, my old friend DK Everett, who I love dearly, you know, he has a company called the Compliance Division in Texas. And he once told me something that I've never forgotten. And that is, you know, as a compliance officer, a bona fide compliance officer, he doesn't care if his recommendations are going to make the company money, and he shouldn't care if his recommendations are going to cost the company money. His sole purpose is to keep that company within the four corners of the law.
Now, that said, it's not always as simple in black and white as that.
That's in a perfect world.
Right.
But I do kind of appreciate his position.
And you have to make the recommendations. They may not be followed.
That's right. But as a compliance officer, if that's what it takes just to keep them within the four corners of the law, that's what needs to be recommended.
And you notice they say autonomy and resources, but they don't say authority.
That's the problem. That's the problem. You know, and these poor compliance officers make these decisions that get everybody worked up and upset. You know, it's being a compliance officer these days is like being a baseball coach. Okay, you got 3 good years, and then it's time to find another job.
You're going to be wrong.
That's right.
But anyway.
All right, policies and procedures.
You know, this is kind of like, this is the guts of it, though. All right, so you've got your monitoring, and you've got
your 7 elements. That really could be put in 3 or 4 pages, probably.
But you do have to write down what
underlying policies.
How you're going to do it, what your screening policy is, what you're monitoring. How often are we going to do it? Are we going to do statistically? How are we going to do?
How are we going to monitor? Or how are we going to keep? You know, how are we going to verify that our people are actually showing up at people's houses?
Who's responsible for making sure that we're looking at this billing area and this billing area, and it rotates, and who's responsible for that? You know, you got to have a policies and procedures. There really is. It's got to be written down, and it should be followed.
That's right. That's right. Okay. All right. Risk assessment. Guys, those two slides where we outlined some of the risk issues of home health agencies and hospice agencies. Those are general risk issues. I mean, frankly, I think they cover pretty much every home health and hospice. But your particular home health or hospice very well is going to have its own particular risk issues, especially if you take Medicaid. Okay, because that throws in baseballs that from left field that no one sees coming.
And you should have, so when you're looking at these, when you're making your risk assessment, you know, it kind of comes together. You should have policies as to how you're going to deal with those risks that you're looking at. How often are we going to look at the individual risks? So I mean, it kind of comes together. It's one thing, but you know. This is how you look at it, you do your gap analysis, and then you write how you're going to deal with it.
And don't be afraid, by the way, guys, to document problems. And here's why I say that. If you find a problem, let's just say that you find that a plan of care was insufficient, or that the doctor didn't sign off on the care, and therefore it didn't qualify for payment. All right, pay the money back, document what the problem was, and add that to your list of things for training. Okay, and the reason I say this is, if you are audited, and you will be audited, you're talking about home health and hospice. You guys haven't been out from under the microscope in decades. Okay. But when you are audited, if it's something serious, I'm not talking about an ADR from the MAC, I'm talking about something from DOJ or from OIG, you want to be able to show, hey, we have a bona fide living and breathing compliance program. When we identify problems, okay, we pay back any money that's owed and we take remedial action. Bad guys don't pay back money. You want to be able to show you're a good corporate citizen. You're not perfect, but you're trying your best.
Here's something that I'd like to throw out there about audits. You know, when I would go out to a company and they would do probe audits, and then they would want to not necessarily hide them, but they were afraid to show the government that they were doing probe audits because they would think, oh, they're going to now think that there's a new area. You know, when you're looking at a small area and it's not statistically valid, and you're looking at a few claims and you see that there's an issue, if you're going to look further, okay, get a lawyer. So that when you look further and if you're doing a real audit to see, then it's protected under attorney-client privilege. Yeah. You know, you don't want to so you do these smaller audits, and it's good, and you can show that we did these, and as soon as you hit a smaller audit that like hits what appears to be a bigger problem, stop the probe audit, but now hire an attorney, do it, or get it under an attorney-client privilege, and then figure it out. Either way, if it's a small thing and it's a couple, you pay it back. That's great. If it's a larger thing, you're going to have to pay it back anyway. But do it and protect yourself a little bit.
Yep, I agree. Next slide. Training and communication. Training is always important. You know, it really comes down to almost every problem that you run across in home health or hospice. As you said in the first slide, it's all about the people. And that's it. It's about the people.
It is. It's interesting I don't know why they put hotlines under this, because that doesn't seem to be either training or communication.
No.
But hotlines are under this element, and they're stuck in under the 7 elements too. You need to have a way for people for employees or anybody else to anonymously make reports. The sooner you find out about something, the sooner it can be fixed, the cheaper it is to fix it.
Yep. Next slide.
Don't go away in healthcare.
Hotlines are also under this one. Okay. Confidential reporting. You know, so hotlines are something that the government is starting to emphasize now. DOJ is looking at it very seriously. The OIG hotline, just to let you know, gets, how much is it? 12,000 reports a month?
A lot. I don't remember.
That's what it was last time I looked at it. 12,000 calls a month.
Right. You'd rather them call you than the OIG. The OIG may ignore it, but you know,
chances are though, if there's any meat to it, they're going to look into it.
And you know, every employee unfortunately is a potential relator in a False Claims Act case.
Yep.
And you don't want to think of it that way, but you know, if you ignore problems, I have been on all sides of this, and every relator has always said, I made complaints, I reported it, and the company ignored it. So when somebody reports something, don't ignore it.
I've never worked on a key TAM case where the relator, the whistleblower, didn't say, I told them. They either ignored me or ultimately they ran me out.
Right. So
don't
do either one of those.
Don't do either one of those things. Listen to what they had to say. Look into it. Maybe they're right. Maybe they're wrong. But you need to find out.
Right.
Okay. Incentives and disciplinary measures. Okay.
I'm still not sure how you reward someone for doing the right thing. What is that?
Reward ethical behavior and compliance. I'm not real sure either how you do that. Sure, our friends at DOJ can tell us.
Yeah, they'll tell us.
Yeah. But the bottom line here, though, is if you find somebody that's doing something bad, you have to take disciplinary action, because that's the first question that DOJ is going to ask. Right. You're going to say, okay, so you found the bad guy here that did this. What'd you do to him?
Right. Number one, I think, was, find out what happened and what did you do?
Yeah.
The follow-up to that is, okay, did you do anything to the wrongdoer?
Right.
Did you fire them? Did you discipline them?
And moving them around to another section is not what they want to hear.
Right.
Okay, next. Continuous improvement, periodic testing and review. Once again, this is the subset of element 1, internal auditing and monitoring, right?
Continuous improvement, really? How do you measure that? But
Especially in hospice.
sorry, that's not funny. Periodic testing and review, that's auditing and monitoring. Go to the next slide, Gio.
Third-party management.
I can't.
Third-party management. All right. So, due diligence, you have to monitor what they're doing. Once again, these are more people that you have to screen. It's not just enough to screen your employees and your independent contractors. Whoever you're doing business with, the government doesn't want them doing business with you if they have been excluded from participation.
Probably the most important, if you're not owned and have a third-party management kind of situation, the most important third-party that you're dealing with is your billing.
Yep.
If you have a biller,
Yep.
a third-party biller, and that is important to make sure that whoever's doing the billing, that you're all square with that. You don't just leave it in their hands or what have you, because that can lead to trouble.
All right, next, mergers and acquisitions. We already talked about this one, really, what the DOJ is looking for in there. They want to make sure that when you're selling a company, that you're being completely transparent about, what are the hairs on this dog,
And many sales these days have the set off that they're,
they'll put over in some escrow account to cover this kind of stuff. It's never enough, by the way. No matter how much they say that they're going to set aside, it's never enough. So that's something you really got to watch out for. Next slide. This is just a summary of the 11 factors that DOJ looks at. Now, remember, all this kind of folds into the 7 elements of your compliance plan, but these are the 11 things that DOJ looks at, okay? It really, in my opinion, it's just a different way of slicing up that
same apple.
Same apple. It really is. They're going crossways instead of horizontally, or vertically.
I think they hired a compliance person, and they
have to come up with something.
It keeps them busy, so it keeps them in.
Yeah, what do you do when OIG did such a... And OIG, I don't agree with them on a lot of things, but they did a great job when it comes to compliance. I really believe that. They really did.
So, anyway.
They didn't leave anything out. All of these things fall within one of those 11 elements.
If you're within you should be developing the compliance plan. It's going to be evaluated by OIG if they're investigating you.
Yep.
They're going to look at your compliance and how you're doing it. If DOJ is involved, they're going to be looking at it. They're all looking at the same thing. They may have different names for it. And as you say, Robert, from the beginning, auditing, monitoring, knowing your people.
That gets you a long way towards compliance.
Oh, and paying, and don't pay and be careful when you pay people. Don't pay. Yeah. Don't think that in healthcare, in the rest of the business world, in the real world, if I scratch your back, you scratch mine. That's been the way it always has.
Good business.
That's right. And so a lot of business people have gone into healthcare. Why? Well, because as Willie Sutton said, that's where the money is. So businessmen without a background in healthcare come into healthcare, and they kind of bring that same ethos. And it worked fine when they were in the car business or they were selling cars or whatever they were doing, right? But when they come into healthcare, they think they can sell. So you've got to train them if they're coming over. You've got to understand how that's the 3 things right there.
And keep in mind, we don't have a slide on it, but keep in mind, if you look at the statistics for last year for the DOJ Criminal Division, this is the group that looks at everything from antitrust to Foreign Corrupt Practices Act violations to bankruptcy fraud to everything you can imagine.
Right.
By far, the 800-pound gorilla is healthcare. Healthcare runs DOJ at this point.
And the gorilla within the gorilla is kickbacks. It's basically kickbacks.
Yeah, next slide. I'm so glad you said that. Nope, go up one. There we go. That's really it. You're right, Paul. That's the problem for home health, especially, partially for hospice, but especially for home health, is these different business relationships, whether it's an improper lease arrangement or an improper medical director agreement.
Follow the money. As I
Follow
said,
the money.
they're
That's
going to look
exactly
at
it.
where the money is going out because they're going to assume if you can't explain it. So here's the way the prosecutor looks at it. If you can't explain it, then it was for something wrong.
Yes, that's right.
That's basically it. If I give money that I can't explain for something, then the chances are then that's going to circuitously or directly lead to a referral back.
And keep in mind, there is no de minimis under the anti-kickback statute. It doesn't say you can give somebody up to $25 and, before it kicks in. No, it's zero.
Right.
So, we're coming up on Christmas. I know you want to say thank you to your referral sources because if it weren't for them, you wouldn't be in business. But you have to be careful. Technically, that fruit basket is a problem. Now, have I ever seen a prosecutor go after a fruit basket? No. But have I ever seen a prosecutor go after somebody and say it was an improper kickback because they gave a referral source liquor? Yes, I've seen that.
Absolutely.
And I've seen it for sporting event tickets. And other types of things. So you got to be really careful
about how you say things.
Yeah. Sometimes just a handwritten note.
Were there any questions?
Yeah, there's. They're just saying they love talking.
Oh.
Well, thank you, Keith. Thank you very much. We appreciate that.
Okay. The bottom line, guys, let's go back to the very last slide here. Okay. We were tasked with telling you what is DOJ going to look at. And I think we covered that. We covered the 11 things that DOJ is going to look at with respect to your compliance efforts if you ever get in trouble from DOJ. But in my opinion, what you need to do, focus on the basics. Focus on a good, strong 7-element compliance program that is real. Focus on reviewing your relationships, review your LCDs, and review the coverage materials that you've got out there from Medicaid. And, look at the basics, guys. And if you find things that are wrong, if you find overpayments that have been made, pay them back. And document that you paid them back. Last words from you, Paul?
I think you covered. I think we've got it, Robert.
Okay.
So I don't think we have any questions.
No, I would encourage you, if you're not currently using exclusion screening for your screening, call Paul.
Give me a call.
Give him a call. And there's his email. His phone number's on the first slide.
All right. Well, it's a pleasure as always, Robert.
Thank you, Paul. I do appreciate it. I know for a fact that you handled a lot. In fact, some of the stories that we've shared over the years with your cases in Louisiana are just, they're classics. Can't talk about them on this call, I'm afraid, but they're good.
Maybe someday we'll do a webinar of cases that you would really find interesting.
Yeah, you've got a bunch, that's for sure. You've got a bunch. Okay.
All right, my friends in Louisiana.
We love our friends in Louisiana. God bless you all. And if you have any questions, give us a call.
Thank you so much to our presenters, Robert and Paul, for that information, and thank you to our attendees for joining us today. I'll be sending a copy of the PowerPoint slides tomorrow, and if you have any further questions, please reach out to them, like he said, and have a great Tuesday.
Thank you, Gio.